Hello everyone. My topic for the presentation is primary angle closure glaucoma, which we will be understanding under the following headings. Number 1, definition of angle closure. Number 2, epidemiology. Number 3, predisposing factors. Number 4, pathomechanism. Number 5, primary angle closure disease. Number 6, classification of primary angle closure disease. And the last and seventh, absolute glaucoma. First, we need to understand what is angle closure. As you can see in the picture, in the right side of the picture we have open angle and the left side we have closed angle. In the left side we can see the peripheral iris is mechanically blocking the trabecular meshwork and causing the obstruction of the iridocorneal angle. It is called the angle closure, which will further lead to the obstruction of aqueous outflow. The primary angle closure occurs due to the anatomical predisposition without any secondary pathological cause. The ratio between primary open angle and primary angle closure glaucoma in Asian Indians is 1:1, and the prevalence in East and Southeast Asian is 1.4 to 4.3%, which is age dependent, and the estimated prevalence by the year 2040 is more than 32 millions, which is around 3.2 crores, and it is more in the females as compared to the male. The predisposing risk factors are demographically it is more common in the age above 40 years, and for pupillary block it is common in between 6th to 7th decade due to the increased thickness of lens and anteriorly positioned lens and senile meiosis. As per gender, male is to female ratio is 1:3, common in females due to the shallow AC, and as per race, Caucasians have prevalence of 6% and more common in 6th decade, and for Asians it is more common in 5th to 6th decade, and around 50% of the cases are of primary type. The anatomical and ocular predisposing factors are hypermetropia with shallow AC and short axial length, the iris lens diaphragm anteriorly placed, the narrow angle, which may be due to short eye, large lens, bigger ciliary body, more anterior insertion of iris into ciliary body, the last plateau iris configuration or thick peripheral iris roll. The ocular biometrics for predisposition will be axial length less than 22 mm, anterior chamber depth less than 2.5 mm, lens thickness more than 4 mm, and lens thickness axial length ratio more than 20%, and the hereditary predisposing factor will be shallow AC, narrow angle, which is more common in first degree relatives, and the pupillary block type is a sporadic in occurrence. The pathomechanism will be pupillary block mechanism, plateau iris configuration, and syndrome. The pupillary block mechanism, it is responsible for increase in IOP in around 70% of the patient, and the precipitating factors will be first physiological mydriasis, which can be present in reading in dim light, watching TV or cinema in darkened room, anxiety, emotional stress due to sympathetic overaction. The second will be pharmacological mydriasis due to topical mydriatics, tranquilizers, bronchodilators, antidepressants, vasoconstrictors. And third one, pharmacological meiosis may be due to the pilocarpine. And the fourth one is induction of Valsalva maneuver. The drugs with potential to cause angle closure will be allergic or cold medications like ephedrine, diphenhydramine, bronchodilators such as ipratropium bromide, tiotropium bromide, antidepressant, anxiolytic, antipsychotics such as fluoxetine, paroxetine, amitriptyline, imipramine, hydroxyzine, chlorpromazine, antispasmodic, tolterodine, oxybutynin, GI drugs, cimetidine, muscle relaxant such as orphanadrine, trihexyphenidyl, anti-nauseants, promethazine. The mechanism of increased IOP after the mydriasis will be at mid dilatation of pupil there is increased opposition between the iris and lens, which increases the resistance to aqueous flow, which further leads to the collection of the aqueous in the posterior chamber, which pushes the peripheral iris and causes the formation of iris bombae, which leads to the iridocorneal touch and further leads to the increased IOP, which later on leads to the oppositional angle closure, and over time there will be synechial angle closure and the attack will take place, as we can see in the picture. The mechanism of increased IOP after meiosis. There are two types of effects of miotics. First will be intended effect and second will be paradoxical effect. In intended one, there will be pulling of the peripheral iris away from the anterior chamber angle, which improves the aqueous outflow. And the paradoxical one will be there will be relaxation of zonular fibers, which allows the lens and iris diaphragm to move forward. Increased iris lens contact enhances the pupillary block and raises the IOP in the predisposed eye. As we can see in the left side of the picture, there is relaxation of zonules along with the contraction of ciliary muscle, which is allowing the lens iris diaphragm to move forward. The second mechanism will be plateau iris mechanism, which accounts for 10% of the acute angle closure cases. It is also called the angle closure glaucoma without the pupillary block. In the mechanism, anteriorly placed ciliary processes push the peripheral iris forward, which causes the formation of plateau iris configuration, which features shallow peripheral anterior chamber, central formed AC, flat iris configuration, as we can see in the picture. Iridotomy may control the IOP if only configuration is present. But if the iridotomy is done and even after the patent iridotomy there is configuration still present, then it will be called the plateau iris syndrome. In the UBM, we can see the anterior ciliary process preventing the iris from falling back. Over time, there will be progression and the formation of peripheral anterior synecdoche will take place, which further leads to the asymptomatic primary angle closure glaucoma. The treatment will be miotics with laser peripheral iridotomy. The primary angle closure disease. It is the oppositional or synechial closure of the anterior chamber angle. Based on the severity, the current classification categorizes the patients with primary angle closure disease. The classification, as we can see in the left side of the picture, the green circle is depicting the primary angle closure suspect who only have iridotrabecular contact of more than 180 degree, and the orange circle depicting the primary angle closure having iridotrabecular contact of more than 180 degree with raised IOP and peripheral anterior synecdoche, and the red circle depicting the primary angle closure glaucoma with iridotrabecular contact more than 180 degree with raised IOP and peripheral anterior synecdoche along with the glaucomatous optic neuropathy. In the primary angle closure suspect, there will be anatomical configuration which increases the risk of angle closure disease. And in the primary angle closure, there will be already the damage or dysfunction of the trabecular meshwork. And in the primary angle closure glaucoma, we will get the glaucomatous optic atrophy. In the primary angle closure suspect, it replaces the latent primary angle closure glaucoma from the clinical classification, and the symptoms are absent at this stage, but only suspicious clinical signs are present, such as the eclipse sign. As we can see in the first picture, the nasal iris is illuminated when we are throwing the flashlight or torch from the temporal side of the limbus. And in the second picture, The nasal iris is non-illuminated due to the presence of shallow AC when we are throwing the torchlight from the temporal limbus. The second suspicious signs will be the slit lamp biomicroscopic signs, where we will get the decreased anterior axial anterior chamber depth, as we can see in the first picture, and the convex iris lens diaphragm as depicted in the second picture, the close proximity of the iris to the cornea in the periphery, as we can see in the third picture. The third suspicious sign will be reduced Van Eyck's grading to the grade 2 or 1. As what we do in the Van Eyck's grading is, we compare the peripheral anterior chamber to the corneal thickness. In the grade 4, peripheral anterior chamber will be equal or more than the corneal thickness. In grade 3, it will be 1/4 or half of the corneal thickness, and in grade 2 it will be 1/4 of the corneal thickness, and in grade 1 it will be less than the 1/4 of the corneal thickness. The diagnostic criteria will be, we will get the iridotrabecular contact more than 180 degree, or we will get the ITC in 2 quadrants, or we will get the ITC in 6 clock hours in the gonioscopy. An IOP will be normal, no optic disc changes will be present, visual field will be normal. This suspect patient will have the angle which is at risk of the appositional closure, and it will require the close monitoring. In most of the time we will probably get the grade 3 in the gonioscopy, which is the obscuration of the posterior trabecula for 2 quadrants or 180 degree or for 6 clock hours. The management will be, first we will do the provocative test to precipitate the angle closure in primary angle closure suspect. This will be performed in the office, clinic or hospital for the prompt management. First, darkroom prone provocative test, which is a physiological test. Baseline IOP will be recorded. Patient will lie prone in the dark room for 1 hour, as we can see in the picture, and he will be remained awake. The IOP will be measured again, and the increase of more than 8 mmHg will be considered positive. It is the best test for subacute or complete angle closure. The second test will be mydriatic provocative test, which is less preferred. Weak mydriatics are used like 0.5% tropicamide or phenylephrine. The mid-dilated pupil will be induced, and IOP rise of more than 8 mmHg will be considered positive. The positive test will depict the angle is capable of spontaneous closure. The negative test does not exclude the risk, and patient should be informed about the acute primary angle closure symptoms. The provocative tests are not highly reliable and are minimally used nowadays. The second one will be anterior segment imaging. It is important to diagnose the primary angle closure spectrum. UBM imaging is useful in the glaucoma with structural etiology, such as the acute angle closure, pupillary block with forward bowing of iris. It is a gold standard for plateau iris and for the imaging of the ciliary process. As we can see in the UBM picture, on the left side, pupillary block is seen and forward bowing of the iris is also seen. The third will be anterior segment OCT, which will be done for the structural assessment of the anatomical component, quantification of the angle configuration, recognition of the angle at risk of closure, documentation of the progression, measurement of the crystalline lens thickness. As we can see in the left side of the picture, there we can see the light room condition and dark room condition. In the dark room condition, we can see the iridotrabecular contact present in the UBM, whereas we are not seeing the contact in the light room conditions. The treatment will be prophylactic laser iridotomy. It will be indicated if the Positional iridotrabecular contact in the fellow eye is around more than 180 degree. It prevents the progression in the patient with acute primary angle closure or primary angle closure glaucoma in one eye. If untreated, around 50% of the risk of conversion to primary angle closure glaucoma in 5 years. The periodic follow-up will be done. It is essential in the primary angle closure suspects for both eye, and patient education on disease symptoms is also essential. Primary angle closure, the defining criteria will be iridotrabecular contact more than 180 degree on gonioscopy, the elevated IOP or the presence of peripheral anterior synecdoche. Optic disc will be normal. Visual field changes will not be seen, as it will be also normal. The clinical course of the primary angle closure, it may remain asymptomatic or will be progress to subacute, acute or primary angle closure glaucoma. The subacute primary angle closure, it is also called intermittent angle closure. It is characterized by transient IOP rise around 40 to 50 mmHg, and the duration will be few minutes to 1 to 2 hours. It represents an intermediate stage between the asymptomatic primary angle closure and acute primary angle closure. The precipitating factors will be the same as physiological mydriasis, prone position, and pharmacological mydriasis. The clinical features will be unilateral, transient blurred vision, color halo, headache, brow ache, eye ache. It self-terminates due to the physiological meiosis, which will be induced by light or sleep. The recurrent episodes are common and it remains asymptomatic between the attacks. The signs are usually quiet. Primary angle closure diagnosis criteria should be checked. The treatment of choice will be laser peripheral iridotomy. The color halos. The mechanism of color halos in primary angle closure is due to the corneal epithelial edema, which alters the corneal refraction. Spectrum like halos are seen around the lights or moon. The red ring will be outer and the violet will be inner ring. It will be differentiated from acute purulent conjunctivitis, immature cataract. As in acute purulent conjunctivitis, halos will disappear after irrigating the discharge. And in immature cataract, the halos will be broken on the Fincham test. In the glaucoma, halos will remain intact on Fincham test. As we can see in the picture, when we will perform the Fincham test with the stenopic slit, the halos will be broken with the immature cataract. Acute primary angle closure, it is caused by the pupillary block and sudden angle closure. The attack does not self-terminate but persists for days if untreated. It is a sight-threatening emergency. The symptoms will be severe ocular headache or pain radiating along the trigeminal nerve, nausea, vomiting, prostration, extremely weak, exhausted and unable to sit or stand. It also mimics the migraine, rapid vision loss, redness, photophobia, lacrimation. Around 5% will have prior history of subacute primary angle closure attack. The signs will be edematous lid, chemosis, congestion, conjunctival or ciliary congestion. The edematous cornea, insensitive, epithelial microcyst or stromal edema will be present. Anterior chamber will be very shallow, aqueous flare or cells will be present. Angle will be completely closed or peripheral anterior synecdoche may be present. As we can see in the picture, the conjunctival and ciliary congestion is present and lid is also edematous. The iris will be discolored, pupil will be semi-dilated, vertically oval, fixed, non-reactive due to the ischemia or sphincter paralysis. The IOP will be markedly raised around 40 to 70 mmHg. The optic disc will be edematous or hyperemic. The fellow eye may show shallow anterior chamber, occludable angle on gonioscopy. As we can see in the picture, the fine opacities of anterior subcapsule is present, which is called glaucoma flicon. The investigation will be gonioscopy, ultrasound biomicroscopy, and AS-OCTs. The management of acute primary angle closure. It is an ocular emergency which will require the aggressive management. The goal will be immediate IOP reduction, definitive treatment, prophylactic iridotomy of fellow eye, long-term surveillance, and IOP control. The first immediate medical control, systemic hyperosmotics will be used, IV mannitol 1 gram per kg, preferred if nausea or vomiting present, oral glycerol 1 gram per kg if tolerated. It will be avoided in diabetic patients. Systemic carbonic anhydrase inhibitor, acetazolamide 500 mg IV stat, then 250 mg TDS. Topical anti-glaucoma agent, beta blocker like timolol 0.5%, brimonidine 0.1 to 0.2%, prostaglandin analogs latanoprost 0.005%, myotic therapy pilocarpine 2% QID only after the IOP is lowered. It will not be given at very high IOP. It is not routinely used now due to the lens thickening and anterior shift, as I have already mentioned in the mechanism. The supportive treatment will be analgesics and antiemetics, topical steroid like prednisolone acetate 1% or dexamethasone. Indentation gonioscopy can be done to assess the reversibility of the block or to differentiate between the appositional or synovial closure. The definitive treatment will be laser peripheral iridotomy performed once cornea is clear and peripheral anterior synechiae is less than 180 degree. It restores the aqueous flow and relieves the pupillary block. NDIAG or organ laser is preferred. The surgical PI, if laser is unavailable, can be done. Predictors of poor control after laser peripheral iridotomy is extensive peripheral anterior synechiae, high initial IOP, large CDR. Laser gonioplasty, organ peripheral gonioplasty, it is useful in peripheral plateau iris. Peripheral iris burns will take place, which will contract, and then there will be angle deepening. As we can see in the upper picture, the laser peripheral iridotomy is seen, and the second picture is depicting the organ peripheral iridotomy or laser gonioplasty, iridoplasty. The filtration surgery, as we can see in the picture, is being performed, which is trabeculectomy. It is indicated if the IOP is uncontrolled after the laser peripheral iridotomy or maximal medical therapy. Also, if the pass is more than 180 degree or PI is ineffective, it provides the alternative aqueous outflow to the subconjunctival space. Then lens extraction can be done along with the IOL implantation. It is recommended in the phacomorphic etiology or if cataract is present. Clear lens extraction is still controversial but considered in selected cases. Then comes the prophylactic treatment of fallow eye. Laser iridotomy or surgical iridectomy can be done. It should be performed early in asymptomatic eyes. Risk of acute attack in fallow eyes is around 50%. Then comes the long-term management, regular glaucoma surveillance or IOP monitoring in both the eyes done. Then eyes are treated with the laser PI may still progress to the primary angle closer glaucoma. So we need to treat accordingly. Filtration surgery may fail over time and may require repeat surgery with antimetabolites. The sequelae of acute primary angle closure will be the post-surgical acute primary angle closure, After laser peripheral iridotomy, it may be successful or unsuccessful. If successful, IOP will be normalized and eye will be quiet with the walk triad. And if unsuccessful, there will be persistently raised IOP and it will be needing trabeculectomy surgery. The spontaneous angle reopening may be there. It is rare, but the attack subsides without the treatment. The treatment will be laser PI. There may be ciliary body shutdown, temporary cessation of secretion due to the ischemia. It features low IOP, reduced pain, which later converts into the chronic IOP rise and later into the primary angle closure glaucoma. The management will be topical steroids, laser PI, trabeculectomy if IOP is uncontrolled. The Vogue triad will be glaucoma, flaken, sectoral iris atrophy, slightly dilated non-reactive pupil. The glaucoma flaken are the anterior subcapsular lens opacities, and this sectoral iris atrophy will be ischemia of stromal vessels, as we can see in the pictures. Glaucoma flaken in the upper picture and the iris atrophy as in the second picture. And pupil is also slightly dilated and non-reactive to light. The primary angle closure glaucoma, it is preferred term instead of chronic primary angle closure glaucoma, results from the gradual synechial closure of the anterior chamber angle. Primary angle closure may progress to primary angle closure glaucoma over time with or without prior subacute or acute attack. The clinical features will be persistently raised IOP, quiet eye, painless. Optic disc will have the cupping. The Vogue triad may be present if prior acute primary angle closure present. As we can see in the picture, the glaucomatous optic atrophy, the bean pot cupping is seen. The visual field defects which are typical of the glaucoma are, in the early stages we may get the paracentral scotoma, nasal stap or cedal scotoma, and in the mid stage we can get the arcuate scotoma, gerum scotoma, or in the late stage tunnel vision and temporal island, and end stage will be the total blindness. The diagnostic criteria will be redotrabecular contact of more than 180 degree, primary angle, peripheral anterior synechial formation, elevated IOP, optic neuropathy, visual field defect. The angle is abnormal in function or structure, abnormal in function as in because of the raised IOP, and in abnormal in structure due to the presence of peripheral anterior synechial with optic neuropathy. How we will assess the advanced stage? In advanced stage or disease, there will be IOP of more than 24 mmHg or visual acuity will be less than 3/60. If disc or field cannot be assessed due to the media, we can get the disease is advanced by the history of glaucoma surgery. If we cannot see the media or posterior segment due to the hazy media, like if the person is having cataract, so if the history is consisting of glaucoma surgery, we may, and patient has less than 360 vision and IOP is more than 24, we may assume the patient is having advanced disease. As we can see the field defect in the glaucoma, the first in the picture you can see is barring of the blind spot. In the second one, superior paracentral scotoma, then third one is cedal scotoma, then fourth is gerum scotoma, then fifth one is double arcuate scotoma with rainy central nasal stap. Investigation and treatment. In investigation, gonioscopy will be done to assess the angle closure and peripheral anterior synechial. Anterior segment imaging like UBM and ASOCT will be done. The treatment for first line will be laser peripheral iridotomy with medical therapy. If uncontrolled, trabeculectomy or filtration surgery will be done. In prophylactic therapy, laser iridotomy in fallow eye will be done. The absolute primary angle closure glaucoma. It is the final stage of untreated primary angle closure glaucoma, also called absolute glaucoma. The clinical features will be involving completely blind eye, painful and irritable eye. There will be perilimbal reddish blue zone, which will be having ciliary flush from dilated anterior ciliary veins. There will be prominent vessels in the long standing cases, caput medusa, early clear cornea or insensitive cornea, which may later lead to hazy and may develop epithelial bully or filament. Anterior chamber will be shallow or very shallow. Iris will be atrophied. Pupil will be fixed, dilated. Greenish hue may be present. Optic disc will have glaucomatous optic atrophy, and IOP will be markedly elevated, and eyeball will be stony hard. The management will be the retrobulbar alcohol injection. 1 ml of 2% xylocaine will be given. Then after 5 to 10 minutes, 1 ml of 80% alcohol will be injected. It will release the pain by destroying the ciliary ganglion. Then second management will be destruction of ciliary epithelial, which is secretory in nature, and method will be cyclocryotherapy, cyclodiathermy, cyclophotocoagulation. It will lower the IOP and relieve the pain as well. The complication will be corneal ulceration, staphyloma formation, atrophic bulbi, corneal ulceration due to the prolonged edema and insensitivity. It may perforate, and due to scleral thinning there will be bulging, and ciliary equatorial staphyloma may take place. Due to ciliary degeneration, IOP will fall and eyeball will shrink and land up to atrophic bulbi. The take home message will be primary angle closure can be asymptomatic or progress to acute primary angle closure or primary angle closure glaucoma. Early detection with gonioscopy or ASOCT is crucial. Acute primary angle closure is an emergency which will require immediate IOP control and laser PI. Primary angle closure glaucoma causes optic neuropathy, and end stage will be absolute glaucoma. Fallow eye prophylaxis and long term follow up are essential. Thank you.